we'll just go ahead and dive into the discussion. Some of the slides I used are from a previous presentation, so that's why I included Dr. Yoshimoto. She was my co-chief when we first did the project of trying to integrate crisis management with primary care folks. So I have no financial disclosures, as is true with her as well. So for our learning objectives, after this presentation, you should be able to describe the major risk factors and utilize appropriate scales, determine the most appropriate management of a mental health crisis or safety concern, and then guide families in obtaining relevant mental health care access and resources in the community. And then, as we discussed, I think this is especially prevalent given how we've seen the pandemic cause a surge in mental health needs, not necessarily a surge in mental health providers. And therefore, there's a lot of backups. And I feel like PCI's really important area to expand upon, because a lot of these kiddos end up with all our very, very helpful pediatricians and primary care providers that, have to practice outside their scope of practice for initial kind of management. And I know it's a big daunting task, and we really appreciate you guys stepping out of your comfort zone, but want to give you guys the right tools to help guide decision making. So the first question, which of the following indicators is least concerning and doesn't necessarily make you have to go to the emergency department? So we have suicidal thoughts, suicidal intent, suicidal plan or details, and suicidal plan preparations. And I believe we're going to go over the answers at the end, but it's just a pre-test to see what people are thinking.
Yeah, so you can go ahead through all three questions, and then I'll give everyone enough time to see how we're getting.
Okay.
I'll kind of check it like that. Yeah.
Okay, so I'll roll through the next two. Question number 2, what is the way to obtain local assistance if not a life-threatening emergency? And the choices are 988, that's a new hot topic, 911, access line, which is also now, I think, rebranded as care line, 832-3100. And then you just yell out the window and hope someone comes. And then question 3, which of the following does not allow the family to access DOH CAMHD services? And that's Quest Insurance, Individual Education Program, or known as an IEP, judiciary involvement, or a 504 plan.
I'll give it about 30 more seconds. It's about 3/4 ways done. Okay. All set.
Alrighty. All right, so diving in, I thought everybody did an awesome job with the first question. Can make my crisis talk pretty easy. So yes, so suicidal thoughts, that's the big thing that comes up to a lot of PCPs and pediatricians when families come in worried about their kid expressing self-harm or suicidal thoughts. So the first slide, do I share results, or what do we do, Summer, to get out of this thing? You close? Okay, so it looks like it's out. Perfect. Okay, so for crisis intervention and prevention, the first slide we're going to go over through is the flow chart, and then we're going to go through prevention plans, how to guide the parents and resources. So next slide. So with the safety concerns in crisis, usually kids are coming in with either like some kind of behavioral agitation or some kind of new bizarre behavior that's concerning, or they're flat out saying, I want to hurt myself or I want to hurt other people. So usually the next questions I ask when kids come into the ER is, especially like if there's a safety concern, do they have a specific plan, right? And is this plan evolving into something they're actually thinking about acting on versus just kind of a rumination? And how long has the patient felt this way? Is this something they've been thinking about for weeks, for months, or is this something kind of impulsive in the spur of the moment because they're feeling really heated? Whether, it might be due to a conflict with a friend or family member. And then what is the lethality of this plan? Obviously, I don't want to minimize like overdoses, but, most of the overdoses aren't lethal, can oftentimes be reversed versus hanging or by gun violence, right? Like those are things that have more lethality. And if there's any kind of intoxication, so is there any concern that there was recent alcohol or marijuana, meth consumption that might decrease inhibitions? And so if there's not as much of a concern, we could look at close follow-up, right? Excuse me. So referral to a mental health provider. Sometimes it's more frequent follow-ups, having them check in consideration of a crisis plan that can help the parents and patients to reference should things worsen. If they need immediate evaluation, it's always best to recommend they go immediately to the nearest emergency room, dial 911 for emergency assistance if they feel like they can't transport the child safely, or calling Access Line to have a crisis mobile outreach representative come in and evaluate the kid and see how they can help. Next slide. So next up, we have the Columbia Suicide Severity Rating Scale. So in that case, a lot of times when they come into Queens before, we would always initiate the scale. Excuse me. So just looking over the questions, you can see which of the following areas, like you guys appropriately answered in the questionnaire, would determine more significant risk that would be of concern. So again, if there's been a plan and then it's evolved into some kind of intent, that would be more concerning, especially if they've started to take preparatory acts. And if yes, then they should seek behavioral health care by going to 911 or the nearest emergency room. Next slide. I do have a honey lozenge. Thank you. I'm just waiting for it to kick in. Appreciate it though. All right. So for crisis prevention plans, they're basically intended to help the children and adolescents kind of notice triggers or warning signs. Also looking for coping skills that they can try to utilize if they find that, the thoughts are worsening. And who else they can reach out for if they feel like they can't do it on their own, so other supports. Next slide. So here's an example of a crisis plan. And triggers can be physical sensations. So sometimes the kids can identify the trigger as being like a specific topic that makes them feel very emotionally heightened, or can also be certain situations. But sometimes even if they can't clue themselves in and they're not aware of a particular theme or situation, sometimes it can be like they feel like their heart is pounding, their fists are clenched, their jaw is tight, they're short of breath. So sometimes physical sensations are helpful for kids to clue into before they can really identify the situation or the context. I like to tell them that coping skills, another way of thinking of it, is a distraction technique. So for some kids, it's like taking a walk, listening to music, reading a book, playing, 5 minutes of a game on their phone. Other supports I kind of explain to them are safe contacts or environmental measures. So safe contacts can be family members that they feel they can reach out to and talk about their problem and help de-escalate. And environmental measures might be even kids telling parents to lock up sharps and medications, things that they can be kind of taken impulsively. Um, Again, it's not that you have to make your house completely baby proof, but like thinking of like a block of knives in your kitchen. You probably use two pretty regularly. You don't use the other ones as much. Um, so part of it might be just making sure those things are secured so that if there's only two knives and one goes missing, it's really apparent really quickly. Um, Versus like even again, like if they really wanted to hurt themselves, even if you locked up all the medications, over the counter stuff, cleaning solutions, whatever might be taken impulsively, they really wanted to harm themselves, probably could walk to the nearest longs and get something there. But at the same time, the whole point is to decrease the impulsivity and the access. It gives them time to slow down and think. Maybe walking over there is a coping skill, and it'll kind of let them take time and slow things down to actually think about how they're feeling and if they really want to do this. Um, and then resources can be numbers that they can reference, such as the local crisis lines, 911, if they have a therapist or psychiatrist, or again, going to the nearest emergency room if all the other steps have failed. Next slide. So parents often ask me, what do I do besides, that environmental safety we talked about? We talked about also kind of decreasing stress. So obviously, if school's a stress, we want to figure out how much we want to let the school know and whether or not additional accommodations need to be considered or made. And then this stance, I'm thinking of like extension for a deadline or more time for a test, 504 kind of or IEP discussions. But I still tell them to encourage regular school attendance because sometimes the avoidance can make things more reinforcing and harder to get back when they are needing to get back to school. And then also, like we said, we mentioned securing anything that might be potentially harmful. So I tell parents a lot of times it's helpful to go to like City Mill or Home Depot, buy one of those toolboxes, throw all that stuff in a toolbox, lock it up, and throw it, into like their bedroom. Sorry, somebody's not muted.
Good job.
Um, but yeah, so just thinking of like again a way to secure as much of the stuff as they can. Some parents might throw stuff in a Tupperware and put it in their trunk of their car and leave the keys, or put it in their room, so the kid doesn't have access to them. Every family has a different threshold for what they're comfortable with and what they feel would be helpful. But again, it's just decreasing immediate access. Next slide. Here's some crisis intervention and prevention numbers. If there's any that you need, I actually will be at the end of the talk, be giving you guys a way to get to the manual that we made in my chief here with my co-fellow that has all these resources for your reference. Next slide. So the big hot topic that everyone wants to know about is what is about this 988 number that just had a soft launch. So we'll be going over about what it does, what this means to the kids in regards to anonymity, and what if any immediate assistance is needed. Next slide. So basically, this is fairly new. On July 16th, the US had the soft launch of this new emergency number that's supposed to be analogous to 911, but it's specifically for mental health needs. It's 24/7. People can use it to reach out for mental health needs or even substance use crisis, either by calling, texting, or chatting. And I think the plan was basically to connect it to the existing national suicide prevention line. And for those of you that don't know, the text line is 741-741. So the way I like to reference it with the parents is if you look at the dial pad, the first column, if you go backwards from the bottom to the top, is 741-741. Excuse me, next slide. So if they call this line, what they're going to get is a trained counselor that can walk them through their crisis. 911 doesn't really get trained to do that. So if anything, they're more triaging the calls so they can dispatch emergency personnel. So a lot of times 988 allows the counselor to talk and spend the time that's needed to help de-escalate the situation over the phone. And if they need more assistance, then the call center can basically get the right resources and emergency personnel to them if it gets to that point. And activating 911 is still the last resort if there's an imminent risk. So, meaning, like, for example, there's somebody who just overdosed on an opiate, right? And that's something that needs immediate medical assistance. But again, fortunately, this is only 2% of the suicide calls. But again, that should actually not go to 988 first. It should go straight to 911. Next slide. How is the call routed? So this is the one thing I found that was really interesting and opened my eyes to realizing that it's not foolproof. So the call's routed to the nearest call center based on your area code. So this has been a big problem even with the military kids I see, because most of these kids have a area code that's not 808. So if they're calling 988 and they're in crisis on island, but their area code is like Vegas, for example, then they're going to get routed to like Vegas's 911 dispatcher. Not ideal because again, they want to maintain anonymity and not use an actual geographical locating kind of feature like they do with 911. But again, like not helpful if there's somebody that actually needs somebody to go out to them. So I know a lot of this is still soft launch. So advocacy groups are trying to figure out, what kind of things can be considered moving forward, just because anonymity versus privacy, risk versus benefit, right? And so that's something that I like to tell folks. You can call them and you can talk to them, but if you're actually needing local help, it's actually still best to use our local crisis line. So go ahead and go to the next slide. So 988 again is a good one to advertise because it's easy for kids to remember. They're still going to get a good response from a trained crisis counselor. And again, still reminding them 911 is still the emergent number if you need somebody to come immediately. But even then, a lot of times I still reference, even though 832-3100 isn't as sexy sounding as 988, it's still going to link you to our local resources. And even then, like the local crisis mobile outreach will be more familiar with additional local resources that can kind of help you get linked in versus obviously a national hotline is not going to know what's available specific to Hawaii. Next slide. So that's pretty much the gist of my crisis talk, but I do know people always have the $1,000,000 question. Okay, so if it's not like a 911 emergency room kind of crisis, now I have this kid in front of me. How am I gonna manage? Oh yeah, perfect. It is an 808. So 832-3100 is our local number. So 808 is the area code that is specific to Oahu. But I will say that in the information packet that I'll reference at the end, you can see the numbers for the neighbor islands because it's a little bit different for the neighbor islands. Thank you. Great question. For anxiety specifically, I actually found a really good reference through Seattle Children's Hospital. So next slide, please. So for each of the diagnoses we're going to be going over, I do have a flow chart that I reference from Seattle Children's, and the web address is there as well. I'm not sure if they've updated it since 2017, but fortunately the practice parameters haven't really changed significantly. So I still feel that it's relevant. Next slide. So a really helpful tool to give the families, and they can fill it out themselves, is the Scared. It's free, it's online. You can also print them out. There's a parent form and a child form. And so this one is really helpful in kind of teasing apart different kinds of anxiety. Will it change the management? Not necessarily, but if you needed more guidance to what specific anxiety the kid had, this would kind of help clue you in a little more. Next slide, please. Again, from Seattle Children's, there's a nice little kind of like chart to show what are the common SSRIs we use to treat anxiety. I will say our go-to for both depression and anxiety on the child psychiatry inpatient unit is either usually fluoxetine, sertraline, or escitalopram, just because there's more data and studies on it. And I will say that obviously, we also can rely on the FDA indications as well. That often gives a lot of parents reassurance. So for pediatricians and primary care providers, I think most will at least start the initial dose and then monitor and then maybe titrate up to the next highest dose. But if it starts to feel like it's a little overwhelming because of potential side effects or, you know, I guess requiring higher doses to treat, obviously always more than welcome to send over our way. But most of the time, the SSRIs take about 4 to 6 weeks to even build up in the system. So it's always helpful if one of the first line ones can be started and loaded in the meantime. Next slide. So yeah, we always tell families, you know, a lot of times if trauma is involved, we always have to make sure that there's safety. So always trying to assess with the child if their anxiety is specifically related to a trauma, trying to look for the DSM criteria for PTSD, and also, you know, referrals to more appropriate resources. So for example, with PTSD in adults, most providers tend to prescribe an antidepressant and then do trauma focused cognitive behavioral therapy. But with the kids, they actually don't have compelling evidence that medications are the first line and that trauma focused CBT is best. So I think a lot of times, I guess, especially the Kapiolani folks, referrals to SATC and kind of getting linked up to the right trauma related resources is key. Next slide. This was one of the apps that one of the actually kids brought up that they found was pretty helpful, called the Virtual Hope Box. But also, a lot of times I'll tell kids because they all look at YouTube and stuff like that to look up different things for mindfulness, progressive muscle relaxation, deep breathing. I'm sure nowadays there's probably even like TikTok videos on this kind of stuff. But that being said, those are good search words for kids to look at. Next slide. Autism spectrum disorder. So the reason why sometimes this ends up in a crisis management situation is the kids become teenagers. They experience bodily changes that are unfamiliar. They're very sensory oriented. They're used to consistency. Adolescence is nothing but inconsistencies happening left and right, and also changes to routine. And I think a lot of especially autistic boys, are noticing that, you know, increase in testosterone equates to increase in some aggression, physical size. They're much bigger than their caregivers now. So that's when sometimes some of the crisis stuff comes up. Next slide. So again, a little flow chart to kind of guide how Seattle can kind of walk you through autism treatment. Next slide. And then I know this is something most of you are all familiar with, the MCHAT. Next slide. And then medication consideration. So no, unfortunately, good medications for the treatment of autism, but there are medications that can basically address the aggression that's related to autism. And a lot of times, most of us will go to low dose risperidone or aripiprazole. But of course, that comes with a whole slew of potential side effects that we're going to need to monitor with appropriate maintenance labs, like, you know, your metabolic concerns, hemoglobin A1C, fasting glucose, and lipid panels. Next slide. The main key is ABA, or applied behavioral analysis. I know this is a huge bugaboo because it's really hard to find an ABA therapist in Hawaii, especially if you don't have TRICARE or Kaiser. So I know this is one area that we're trying to see. I know HMSA has been somewhat responsive. I will say, I think when I was inpatient before, maybe I had like 1 or 2 kids that had HMSA that were somehow magically able to get this coveted unicorn ABA access, but I know it's still a huge deficit that we have here in Hawaii. Next slide. And this is a website that a lot of times is helpful for some of the families to start off at. Next slide. And this is specific Hawaii autism resources. So different places you can try to reach out to. Next slide. Bipolar disorder. So again, sometimes looks like depression, but obviously can cause a lot of mood instability and also safety concerns, especially if they're having a manic episode. Next slide. This is the flow sheet, but in general, I feel like if you're really concerned about bipolar, this is something that should go to the ER because the tools you're going to use are pretty heavy hitters. Next slide. Additional screening tools that are available on the internet. So the mood disorder questionnaire and young mania rating scale. But again, ultimately, I feel like this is a big inpatient kind of condition. Next slide. So I didn't put the medication recommendations because a lot of times you guys just send them over to the ER anyways. So here's at least a helpful website for bipolar disorder for families. Next slide. So depression, a lot of overlap with anxiety. So next slide, you'll see the flow sheet too that you can reference of how depression is diagnosed and all that. Sorry, next slide. So yeah, so that's the scale that we would use for screening. So a lot of times people I know use the PHQ-9 as well in pediatricians' offices, but another free one is the CSTC. Next slide. And depression medications, again, look very similar to the chart for the anxiety medications. Again, often go to fluoxetine, sertraline, and escitalopram. Some use of the other medications, but again, I always like to start with evidence-based and well-studied and FDA-approved medications before kind of going to other options. Next slide. Helpful websites for families. Next slide. So disruptive behaviors. So these are kind of thinking more of like the externalizing behaviors. So it's oppositional defiant disorder, conduct disorder, even just sometimes DMDD, disruptive mood and dysregulation disorder. Basically having a lot of difficulties following through with things that they need to do without having a significant amount of irritability or pushback. So next slide. This is the algorithm for thinking about whenever there's a disruptive behavior. It's a little more vague, not as obvious. There's a lot of overlap, like I mentioned. So other things you have to really kind of consider is if this is a dramatic change, has there been recent neglect or abuse, or any kind of substance use? And also, again, this is where the homicidal ideation might come into play a little bit more than the suicidal ideation we previously discussed. And oftentimes, like I said, you have to think of other comorbid diagnoses that can be involved. Next slide. So in general, screening tools, unfortunately, not really any good ones that I've seen or come across, but medications-wise, some people resort to atypical antipsychotics to kind of help manage the disruptive behavior aggression. But again, there's a whole slew of different kind of side effects that you should consider, risk versus benefit. Sometimes I don't have this on here, but I do see people using some of the non-stimulant ADHD meds, since again, there's a lot of overlap with ADHD as seen on the previous slide, to kind of help take some of that edge off, whether it be clonidine or guanfacine, a little more benign than these heavy hitters. Next slide. And then a lot of times I recommend, especially with the younger kids, behavioral therapy management. So timeouts. A lot of times parents can benefit from getting the book 1-2-3 Magic. I found out recently it's also available on DVD if they don't have time to read the book, but it's actually a pretty quick read. Sometimes it's really kind of helping the parents understand special time. So, a time that's set aside for having that one-on-one attention, because a lot of times that positive reinforcement can be more effective, versus the timeout is kind of, again, trying to eliminate the reinforcement by the attention coming from like a negative action, excuse me. And then sometimes people look at also functional behavioral analysis. So identifying the behavior and trying to hypothesize what's driving the behavior and trying to change that via, like I said, kind of adjusting the reinforcing factors. Next slide. And then sometimes some of our kids come in either intoxicated or parents are concerned about substance use affecting safety, and that's their crisis kind of concern. So go ahead and flip to the next slide. A lot of times I'll try to figure out from the kids what drugs are they using, how long have they been using them, how often, and really assessing for safety, right? So are they operating vehicles? And a big problem I see in a lot of our adolescent females, but still a smaller population of adolescent males, is the whole idea of the sex trafficking that's very prevalent on our islands too, trading, sexual favors or their body in order to basically have access to drugs. Or sometimes a lot of our runaways will trade that in order to get food or shelter. Um, so always try to screen for that as well. And also want to draw everyone's attention to if there are concerns for trafficking, you can actually call the CWS line, but there's a specific second line for sex trafficking. Again, because it's been a growing problem in our state over the years. Next slide. So the craft is a good screener for assessing substance use. I always try to tell the kids, you know, anything that has to do with drugs, sex, relationships, especially the teenagers, I tell them, it's confidential. The only time I have to break that trust is if there's a huge safety concern. So again, worried about you harming someone else, harming yourself, someone's harming someone else you care about. That's the only time I have to violate that. But otherwise, what you say here stays confidentially with us. Um, I know before I left Queens, a growing concern was trying to figure out how to navigate the CARES Act or excuse me, CARES Act and parents accessing their kids' charts and what we're documenting in there. I know that's a whole other platform, but I think it's just being mindful of the data you collect and how you document it in order to make sure that you know the kids telling you as much as they're able to, so you can properly assess safety. And that's also what I tell parents. Most parents are pretty receptive to understanding the confidentiality, but some kind of hang their hat on it. And I explain, well, would you rather that they tell me and I screen for what's a safety concern and really let you know what's a high risk versus I tell you everything and then your kid tells us nothing and we don't really have anybody with eyes on what's going on or a good sense of what's going on. Next slide. And then there's some helpful websites for families for resources, both nationally and on island and in the state. Next slide. So a lot of times people ask me, are there resources through the schools? And there are. So a lot of times we'll do school-based outpatient treatment too. You'll have to contact each of these places to see kind of what the current standard is. Because I know when I was doing inpatient during the pandemic, a lot of these are groups and they were after school. So obviously with the virtual learning and then the kind of hybrid model, letting some kids back on campus and some not, obviously, schools are back in full swing now, so I'm hoping a lot of these groups will reopen up with this academic year. But I found that during the pandemic, a lot of stuff may have taken a pause or might have lost funding. So it's always good to kind of circle back and see what's available, as of this month with school being back in play. Next slide. So the question I get asked the most, how to access a provider, because that is just so difficult these days. So a lot of times, I tell most folks to go to their insurance. On the back of the card, there's a 1-800 number trying to see if there's a care coordinator or like a case manager that can help them. Because some of the insurances now actually have a case manager. They'll help guide them specifically through behavioral health resources. And they should be able to tell you also who is practicing and taking their insurance currently and have some avenues and some people to call. Next slide. A lot of times there's also these general Hawaii resources. I found them to be fairly helpful in trying to figure out what's currently available. And it's kind of cool because a lot of them will have specific recent information post pandemic of things that are still working, still available. Next slide. So if your patients, and I think a lot of you kind of know this already just from engaging from the pretest, if your patients have either a Quest insurance or have access to an IEP, they can apply for Department of Health CAMHD resources. So the nice thing about that is there's a case manager embedded in this system. They can try to provide intensive in-home services for therapy. They can try to select if there's other kinds of therapy that are needed, like, for example, our oppositional defiant kids might benefit from multisystemic therapy or functional family therapy. Um, and they also can provide medication management. I personally like it because also for a lot of people, like for example, I use Leeward as a big example. I mean, our Waianae families are having trouble getting into like Pearl City even just to see a provider. So if they're able to have access to CAMHD resources, not as far of a trek, but still a trek from Waianae, there's a Kapolei Family Guidance Center that is at least a little closer because, as most of you know, there's really no behavioral health providers on the Leeward Coast. Next slide. So a lot of times it's important to try to see if they, again, qualify through either an SCBD kind of, and that stands for Support for Emotional Behavioral Development, SCBD avenue, or another one that I kind of mentioned on the pop quiz is the kids who are involved in judiciary. That's a newer route that they've developed. So basically, CAMHD has different family guidance centers, but they actually have a forensic branch called the Family Court Liaison Branch, and that's the one I mentioned I worked at through detention home. And so if they have a parole officer because they have charges and they're involved in the legal system and family court, that is also another way to have them access CAMHD resources as well. Next slide. So to summarize, Quest Insurance, referral from schools via IEP, and then like I said, the newer one that I didn't put on there is the judiciary side. And then also, if they are going to be applying for it, they need a qualifying mental health diagnosis. So they exclude any kind of pervasive developmental disorder because they'll say you got to use DDD services, intellectual disability, or a substance use disorder. If they have comorbid diagnoses, like they have, for example, PTSD and substance use disorder, that would still qualify. Or oppositional defiant disorder and intellectual disability, that would still qualify. The other one they don't like is the kind of general blanket adjustment disorder. So a lot of times if they have adjustment disorder with like depressed mood or anxious mood, I kind of opt for more an unspecified anxiety disorder or unspecified depressive disorder. Next slide. So where can I reference all of today's info? So like I said, I know it's a lot. There are a lot of different resources on the slides. So if you go to the Department of Psychiatry's homepage, a lot of times I'll just put into Google DOP Hawaii, and it'll take us to this website. Basically, if you go to the resources tab and then you click on that, you see I circled the Hawaii Child and Adolescent Psychiatry resources for a primary care handbook. Unfortunately, I haven't got a chance to update it since 2019, but that is a lot of what I referenced today in the slides for you to reference when you need to look up certain either resources, scales, algorithms, and medication guides. Next slide. So pop quiz, I guess we're going back to the poll. So I don't know how we want to do that. Do we just go over the answers, Summer? Okay, go ahead.
Yeah, I'll relaunch the post questions.
Okay.
And Dr. Lam just shared with me a behavioral diagnostic calculator for like the scared screening tool. You put in the answers and it comes out with the scores. So if anyone's interested in that, I have the spreadsheet that I can email.
Yep. It also, pardon me, it also works for PSC 17 and the PHQ-9 and I think one or two other scales. But this was developed by my counterparts at Lurie Children's in Chicago. They kind of put this together for us.
Thank you for sharing that with us.
Yeah, that's awesome because the scared is like one of the most tedious ones to score out of these free scales. So thank you. All right. Should we end the poll?
Maybe another 30 seconds. We're
Okay.
about, yeah. And I did post a lot of the resources. I began posting it on our ECHO website too, as well as a portal website. So it's all there.
Perfect.
Fantastic. Thank you.
We're about 70% done. I'll give everyone a few more seconds to get their answers in.
I always feel like we need to just have like the Jeopardy tune
Yeah.
playing at this point.
Okay.
And actually, I was going to mention, I know on the Tripler side, one of them was circulating a mental health America of Hawaii kind of resource guide. So that one is actually more up to date, but it has adult stuff mixed in it too. So I was going to forward that to Summer afterwards, and then you guys can add that to the resources too. Because again, it'll have some overlap with us, but it's mostly for adults.
And just one of the resources, the Seattle Children's Hospital, when I went online on the link, they put a newer version. So the pages are a little different. So you can reference that on the ECHO website if you guys are interested.
Perfect. That's great. Thank you.
Okay, so the poll is completed. And I'm going to stop sharing it. Okay. So you can go over the questions.
Mine's stuck on, let's see, hold on, so I can take that out. Okay, perfect. All right. So yeah, so question 1, you guys got it. Again, even if a kid has suicidal thoughts, doesn't mean they have to go to the ER. It's more important to kind of look at the Columbia Suicide Rating Scale and tease apart if there's any intent, if there's plan, if there's preparations, red flags that make you think, okay, this is a higher risk, send them to the ER. Next slide. What is the best way to obtain local assistance? So again, that's Access Line, or it's been rebranded as the Care Line, 832-3100. Just because, again, 911 is a life-threatening emergency, and 988 is helpful, but not going to have local access. And if you yell, maybe your neighbor might be able to help, but not in the way you want. So next slide.
The ultimate local access.
Yes, exactly. And then question 3, which is not allow access to CAMHD, it's the 504. Because again, you can have quest insurance, the individual education program, or a judiciary involvement. So yeah, that leaves us a little bit of time for questions.
I was glad to see that the majority of people did better. I somehow managed to do worse. I don't know what happened. Can we take my pre-test answers, please, as like my MOC? I don't have any questions in the chat so far, but we do have another 10 minutes of infinite time to pick Dr. Sy's brain. So if anything does come up, or if any, if you guys have had any cases recently, I know that the hospital is pumping with patients pretty much more or less since early days in the pandemic. And I feel like, they all come in through the ER and then are often on just kind of hanging out at Kapiolani until they can go to a more appropriate facility. So I feel like I'm seeing a lot of these patients, although thankfully I'm usually mostly managing the medical aspect.
Yeah, I will say, fortunately, I still keep in touch with all my inpatient colleagues. It really is hopeful. I will say I'll leave with a hopeful note because I think that this is the first summer we've seen the ebb and flow that we've historically seen. Because, like I said, I did my residency and fellowship here and was an attending for 5 years here. So I've had like a 10-year time frame of seeing like what it was pre-pandemic and then during pandemic and now post-pandemic. And this is the first week, I think, during the summer, like this past 2 weeks, where the census was like at 2 or 3. So that's amazing because usually you guys, like you said, are
Wow.
boarding, waiting for a bed. And so it was
Yeah.
really nice to see that because during the holidays, during Halloween, usually we would see the census dip like that. But during the pandemic, kids would stay in the hospital because it was the one place where they could socialize with peers because everybody was COVID tested to get in, right? Like to be admitted. So people would even threaten to kill themselves or other people if they got discharged from the hospital, you know? And so that being said, I think it's hopeful to see that we've actually seen that honeymoon period before the school year starts of
Mhm.
kids wanting to be out. And hopefully again, we'll see that trend where like, obviously there'll be peak times where we'll be fuller than others, but we won't be full 24/7.
Right. And
Mhm.
kind of backing up to who knows where for who knows how long.
Right.
That's really, I love the positive, promising note at the end. That's very exciting. We did actually get 2 questions
Sure.
at the end. One is being called a potentially loaded question.
Okay.
But what is the one thing that children and adolescents are reported as being missed by PCPs in prevention of mental health issues? That's the one that may be loaded.
Okay. Um, I think it's just, and I think it's not like a criticism of the provider, but just our system, right? Like, I think it's like the fact that you guys are limited to like sometimes even like 15-minute appointments. You know what I mean? Like, it's so jam-packed, and we have the luxury as psychiatrists of like having 30-minute 1 hour appointments if we need to like really get to know the kids and talk. So I think you guys definitely have a lot more longitudinal relationship with the kids because they've known you since they were born a lot of the times. But I think it's just they feel like it's a really short time and you seem really busy and they don't know if that's the right place to discuss it. And obviously we can't make time during the day to say like, oh, I wish I could give every kid like a 30-minute appointment. But at the same time, just I guess when you're asking it, like reassuring them that even though I'm just kind of asking you, I really do want to know. And if this warrants a longer discussion, we can, schedule another appointment sooner rather than later to make the time, right? Because again, I think it's more like they feel like they're kind of a bother or burden if they are trying to squeeze, a very big, like you said, even that was a loaded topic into a 15-minute well child check or something like that.
Mhm. That is such a good point. I honestly, hats off to everyone who is an outpatient primary care. I don't know how you do it. I feel like the hour we have for our admissions is sometimes not enough. So we have here Madeline saying that she heard from Belinda Danielson, who you probably know, that for on the adult side, those with 808 area codes who dial 988 do get directed to Hawaii.
I'm not sure. I mean, if that's
Line.
the case, I would love that because that maybe the whole soft opening created issues and they realized that. I mean, great to see you too, Madeline, on the line. But I want to say part of me wants to even just dial 988 and ask them. You know what I mean? Like, and
That's
see
true.
see what happens, right? Why not? Because if it's not an emergency and you're supposed to have time to talk to me, maybe we can call them ourselves and do an experiment and ask.
Exactly. Perfect. We'll save that for our after echo session.
Yeah.
With all the different area codes too.
Yeah.
Okay, I do have another question from Dr. Wu, which is, what would you recommend for adolescent patients who might come in unaccompanied for follow-up visits, who you are concerned about suicidal threat?
That's a good question.
That's a good
I think that it's hard, right, when they come in unaccompanied and there are concerns. I usually kind of talk with the kid and say like, hey, I'm worried about your safety, but I do want to make sure that your confidentiality is respected. And remember, like we talked about the first time we started having discussions about mental health, right? Is that um, I'm obligated to break confidentiality if there's a safety concern. So I want to empower the kid to be able to disclose what they're comfortable saying to the parent, but that their parent still needs to be involved. So again, I don't like to tell them like, hey, I'm gonna throw you under the bus and like make you under your parents' radar, but I want to make sure that your parents are kind of aware. So I asked them flat out, I'm probably going to call your parent afterwards just to give them an update because I am worried, but what would you like me to tell them? What are you comfortable with me saying? And then maybe recommend a follow-up appointment where you and mom or dad come in, or guardian, whoever the parent is, come in, and then we can talk about it a little bit more together. Because sometimes the kid might be like, well, you can tell my mom I'm having thoughts about cutting myself, but I'm not going to actually do anything to kill myself. But like, I don't want her to like go through my room and take all my stuff and like not let me go out with my friends, So, okay, that's fine. I can let your mom know that you're having some self-harm thoughts, but it's nothing that is life threatening, but that you're agreeable to maybe we carve out more time to talk about this with your mom here next time. And I can help kind of facilitate that. But it needs to be on your mom's radar that some of this stuff is happening.
Okay, that really was a good question. You guys really deal with some very hard things. Okay, last comment, at least that I have so far, is from Janelle saying that I believe there was a new law created recently, maybe 2014, around adolescents being able to access mental health services without parental consent. And then just if you're familiar with this law, and how can we support youth who want the help but may not have the parental support?
Yeah, no, great question. And thanks, Maddie, for putting the website. She linked
Website
it.
in, yes, perfect.
Yeah, and so I think it's kind of tricky because I think it also depends on the system you're in, right? So like when I was over at Queens, I know like for example QCS, a lot of times like they would want the kid to come in with the parent on the first visit to sign all the consent forms. Again, like the other question, they might not be there for all like the follow-up appointments, but even if they're going to do like medication management, right, like medication consent, they still wanted an adult to sign the consent form even to start the medication, right, because they're still the guardian. So I think that there are kind of limitations to what that law entails, because again, are you able to go seek out a mental health provider and provide and get care? Yes, but then again, obviously, if your treatment actually manifests in like again needing medication management, or like I don't know, I'm going to go to an extreme like ECT and you need a procedure, right? I think that that's where a lot of this stuff kind of comes into play, is like we're going to need to have your parents involved at some point to make the decisions. And even then, like insurance wise, right, like when you're billing things, and like even if the kid were trying to like withhold that from their parents are still going to get a bill, right, with like that they went to go see the therapist or psychiatrist, and this is the copay. So I always try to encourage that if they do want to have that, your parents don't have to, it's a lot of psychoeducation, right? Your parents don't have to know what you're here to talk about specifically, but they do need to know that there is a concern, that there is something going on, that there needs to be some kind of approach or treatment. Because ultimately, I think the biggest difficulty is the facilitating, bridging that communication. And it was kind of funny because I used to be on the physician user group committee for Epic at Queens, and people were asking that question because I think it comes up a lot more in pediatrics, right? Because a lot of times they might have like a doorknob question about STI testing or like, mental health stuff. But I find in general, like, again, in order to make a referral or to send them to another provider, a lot of times, again, most providers, even though we can legally treat them for mental health care, often, again, based on the systems they're part of, require some kind of parental consent, and an extra layer even for like medication treatment. So that being said, I kind of approach it even like when kids ask for like an Nexplanon on FTC, they're like, well, technically it's reproductive and my parents don't have to know about it because I can get it put in my arm while I'm here. and they won't know that got it put in, I tell them, well, yeah, you don't have to tell your parents you're having sex and that you're doing stuff, but like, I think it's better that they kind of know that you have a medicine in you so that if there's like an emergency and the doctor tries to give you some medicine in the ER that might interact with it, they'll even know that there's something there, or if you're having a reaction to your Nexplanon and they don't know why, and the doctor's like, oh, well, what medicines are they on? That's kind of scary too. So it's not so much like explaining to them again that they don't have to tell your parents the specifics, but there should be some kind of communication and discussion around that. Because I think the law does allow you to seek out treatment, but I think you're going to kind of be limited by the institution's rules.
Okay. All of these being the parts that make my life, again, just so much easier once they're in the hospital. Oh my gosh. There are 2 more follow-up questions to that question that I'm hoping
Sure.
should be super quick, because I
No
do want
worries.
to be mindful of everyone's time. It's now 1:01. So whether in Hawaii, at what age ultimately that legal confidentiality is, and then are there any records that you can withhold from an adolescent chart who has transitioned to adult care if the child wants their own record as an adult? Ooh,
Yeah,
interesting.
so I think they kind of overlap
Yeah.
a little bit. Yeah, because it's like, again, knowledge including transition to adult care if the child wants. So I think to answer the first question, I give the confidentiality speech to everyone, even the little kids, like the parents who bring in like their 10-year-olds. I say everything we talk about is going to be confidential because I'm not sure of the exact like legal age because again, a lot of it kind of stipulates around 14 and it depends on the state, right? So in the state of Hawaii, consent to have sex, consent to make decisions about reproductive rights, consents to, mental health care, they all kind of start around 14. But I think, we know that there's 12-year-olds probably getting involved in sex trafficking, unfortunately, nowadays. The age is dropping lower, kids are exposed to more. So I always tell the families up front at the beginning, everything we talk about so that we can really screen for safety is confidential. Because again, I don't think that there's a magical age, even if legally there might be one, to what kids nowadays are kind of exposing themselves to and would need to share with their provider. But at the same time, again, I ride the rule of if there's a safety concern, again, a 12-year-old having sex is still kind of a safety concern. Because again, even if it's not even if it's consensual, it's not legally by definition of the state, right, to consent for sex. So if anytime there's a safety concern, more of it in necessarily hard and fast age. But I do want to encourage the communication. And then for regard to the chart, that's an evolution that's been really hard. So literally different committees on all the different hospital systems are meeting to figure out what do we put in the chart? How much do we put in the chart? Do we have the kids sign off after a certain age that their parents need to have permission to access their chart? Do we open 2 separate charts, like a My Teen chart and a My chart, So I think that's definitely an evolving question that I don't have a really good answer for. But I can say in the old records, if the parents didn't want anything disclosed about family history, for example, like the mother has, had suicide attempts, that does all become available to them when they turn 18 because that is